Hi. Hi, my name is Kelly and I'm a CNS currently working in an ICU. This presentation will be reflecting on my ultrasound guided cannulation experience. I have attended 3 consecutively successful cannulation since I finished the course, and I would like to share one of the cases. Patient H, a 78 years old female who was admitted to our ICU due to massive blood loss post left total hip replacement. Her hemoglobin level went from 124 to 68 despite 4 units of packed red blood cells have been given. She was with us for commencing the massive transfusion protocol. However, she only had 2 vascular access and were all in use. Therefore, a new IV cannula is required for emergency purpose. I performed the ultrasound-guided cannulation under the supervision of my vascular nurse and an ICU registrar. During the procedure, I had utilized the ultrasound and sterile equipment includes gloves, IV cannula, IV extension bung set, ultrasound gel, wound dressing tray, chlorhexidine swab, sterile drape, cannula dressing, and the following slide will show the sterile equipment. This slide displays the ultrasound we use in our unit, and here are some more slides with the photo I've taken of the procedures I have attended with the patient's permissions. I felt really nervous before I started the procedure because it is the first time I'm doing this procedure under supervision of my mentors, and I felt even more nervous during the procedure because it was my first time accessing a basilic vein, and it is a relatively deep vein and quite close to the artery than normal superficial vein. At last, I inserted the cannula successfully, and I was relieved, but also disappointed at the same time because it took longer than I anticipated due to inexperience. So during the procedure, I faced 2 difficulties, which are patient's position and accessing the basilic vein. Since the patient H had recent hip replacement, she was unable to roll on her lateral side for me. And another one, she has no accessible veins in bilateral forearms because of multiple scar tissues. Therefore, I had to use the basilic vein in the right upper arms. When I first inserted the cannula, I was unable to locate the tip of the cannula because I angled the needle too deep, and it took me a few attempts to be able to find the tip. To reflect on this cannulation attempt, the poor positioning had increased the duration of the procedure since it has heightened the difficulties to apply the steroid drape, which could lead to increased risk of contaminations. Moreover, because of the way the arm was positioned, it was harder for me to anchor my hands for the ultrasound probe and insertion, and this has led to increased difficulty of dynamic needle tip positioning. And on the other hand, since there were multiple old scar tissues in her forearms, I was unable to locate veins. I had to then insert cannula in the basilic vein, and because it is a big vein, so I was able to use a bigger gauge cannula. However, I went too deep at first because I'm not familiar with the anatomy, and this had increased the duration in searching the tip of the needle, which could potentially cause trauma in the surrounding tissues and increase pain sensation for the patient. But I was still able to put in the cannula in the first attempt with the guidance of ultrasound. In conclusion, I've learned the importance of positioning, angle of insertion, experience, and familiarity with anatomy. In order to advance my ultrasound guided cannulation skills, I will communicate with the ICU medical team and vascular nurse for support and supervisions. I also ensure I seek for opportunities within patients who requires cannulations, observe experienced staff ultrasound guided cannulation technique, and the most importantly, seek for permission to perform ultrasound guided cannulation from the management. These are the reference for this refractive practice. Thank you for your time.